So we have been established in the year 2018, and we have been committed to providing comprehensive training program for the nurses to enhance their capabilities. And also for now, 10,000 plus nursing professionals have enrolled with us, and 25 plus courses have launched, and 35 plus hospitals have enrolled with us. And what is that actually the skills form pyramid talks about? It's about we have 4 stages in our learning pyramid. So stage 1 will be focusing on service excellence skills. That is about when you enter into the healthcare system, you have to know certain basics, like for example, infection prevention basics, and about the communication and about the professionalism. All such courses will be covered here. And the stage 2 will be telling you about the core patient care skills, which is about the bedside skills. And you, after completing all the courses in the stage 2, you will become a clinical expert. And in the stage 3, we talk about the specialization skill. It is not just about being a clinical expert. You have to deep root into your specialization. For example, labor room specialization course and ER specialization course, and also about the infection control nurse program, and also like clinical instructor program. Then after all the stage 3, now you're prepared to step into the leadership skill. So in that leadership skills, so we are talking about like nursing leadership management role, and also about the nursing leadership into the management, and also into the operation system. So which is like your ladder will be like nursing management into like you'll be focusing like in charge, supervisor, and then ANS, DNS, and the CNO, which is the dream of most of the nurses. And if at all after the stage 4, you can decide upon where you can jump into the operations level, where you can become the CEO of the hospital. So this is all about our learning pyramid. And coming to the announcement related to the infection control nurse course program, the skills format, I've collaborated with 𝐏𝐫𝐨𝐧𝐭, and there is a special offer running with this program, which is the 24,000 cost is now given away for the 17,700. The course highlights, I have to insist, it is comprehensive, and most of the nurses after completing it, they have been transitioned the career as an infection control nurse. And to know more about our course details, you can contact Ms. Jayanti, our admin manager. Her number is on the display. And also you can visit our website, which is www.skillsformat.com. Okay. So starting with today's topic, already Mr. Raja Raman have introduced today's webinar title will be on role of nurse-led surveillance in prevention of healthcare associated infection. So I would like to invite our moderator for this program, Dr. Parivalvan Rajavelu, a highly respected consultant surgeon in Sundara Medical Foundation, and he is our visionary founder of Skills for Med. The skills format, I have given you a huge introduction about that. It's a platform which sets for the nurses and for the nursing professional through accessible high quality training with strong focus on patient safety and clinical excellence. He is a passionate advocate for the healthcare quality, and also he plays a key role in 𝐏𝐫𝐨𝐧𝐭. He contributed as a mentor, speaker, GC committee member, and serves as the chair of EndoSafe, actively promoting endoscopy safety across India. His leadership is deeply rooted in extensive clinical experience, ongoing research, and international presentations. And Dr. Parivalvan's unique blend of clinical skill, academic rigor, and system-level thinking makes him an inspiration and a change maker in today's healthcare landscape. Welcome you, sir.
Thank you, Stella, for that introduction. Thank you so much. Can I share my slides?
Sure, sir.
Are you able to see? You're able to see my presentation?
Yes, doctor.
Yeah, thank you so much. Again, thank you for this opportunity, and I take this opportunity to welcome Sister Sai Bala, a very reputed and notable figure in the nursing fraternity. We are very honored to have you, madam. Welcome again. So I'm just going to give a short introduction and step out of the way so that sister can enlighten you all. So I'm just going to talk about why device-associated HAI remains still a major challenge, and explain the surveillance gap and why the timing matters. So we all do the surveillance and mostly it is passive. So I'm going to sort of tell why active surveillance is important and how nurse-led surveillance helps this active surveillance and prevents infection early. So all of you are aware that healthcare associated infections are pretty common. There are several studies from the WHO and also from India saying that the incidence is so high that if every 10 patients who get admitted in the hospital, one of them will be prone to get one type of healthcare associated infection or the other. So this is the sad state of affairs as of today, and we need to do something about it. So let us think why we are still losing this HAI battle. Because we again are aware that healthcare associated infections are mostly preventable. Though they are preventable, we are still allowing it to happen. So why is that it's happening? And it's not that for lack of spending. Hospitals, especially the ones which are aware of these infections, are spending quite a lot of money, but still over the last decade or so, not only in India, all over the world, the infection rates are remaining flat. And because of this, avoidable deaths happen. The patients stay in hospitals longer, and not to mention the NABH and JCA accreditation pain, which happens when your HA rates go up. So, well, this is very, very important to consider. All of us need to think why we are still losing this battle. And I want to argue one of the main reasons for this battle that we are trying to win is being lost because we are focusing mostly on passive surveillance. So we do retrospective chart audits, and there is no real time. What happens real time at the bedside is still a blind spot for us, because by the time we do the surveillance, the patient is not in that bed; they've already gone home. And many times, nurses frequently recognize these early warning signs, but unfortunately don't have the empowerment or the authority to take action. So this is what we are going to talk about today, and this is what I'm really looking forward for Sister Sai Bala to highlight her hospital experience and how they have tackled this problem of nurse-led surveillance. So here is one picture which graphically demonstrates what I was telling. So in retrospective surveillance, if you see, by the time the infection is confirmed, the patient is either already gone home or being shifted to the ICU. So that is what is happening in retrospective surveillance. Whereas if we do active surveillance at the bedside, the nurse sees the signs, but as of today, in many hospitals, the empowerment is not there for the nurses to escalate this problem. So surveillance must move to the bedside, and we need to empower our nurses. So what is active surveillance? I keep talking about it. So basically, it is a very simple process of having a bedside checklist and detecting the HAI very, very early. And also giving the nurse autonomy and rapid feedback loop to the clinicians as well as to the infection prevention control team. So they act like a lighthouse all the time. The nurses will act like a lighthouse in sort of giving the warning signal that there is an infection happening so that we can take quick action. And if that happens, I think we would win this battle against healthcare associated infection. And this is not my fancy idea. There are several studies which show that. Before that, I just want to, you will be wondering why is, suddenly, he's putting this slide. I'm sure many of you would have heard the word or the term Houdini Act. So what does Houdini Act denote? It is a clever escape from challenges. So this is named after this magician called Harry Houdini, who was very famous for dramatic escapes. He would chain himself put several locks, and he will put in a box and be immersed under the sea, and then he will magically appear, on the ship from where the box was put. So this is not any magic, but he had the technique to escape from all these things. So this term, Houdini Act, is used to describe a skillful trouble avoidance or sudden disappearances. Okay, so that is the something which I wanted to bring in. The reason I'm bringing it, just bear with me, is because of this study, which was called Houdini. No, it used this Houdini criteria. This group cleverly used this word HOUDINI to put in certain checklists to make sure that only this group of patients should have a urinary catheter. And if these indications are not there, the nurse was empowered to remove the urinary catheter without even informing the doctor. So this was the study. So H stands for hematuria. If the patient has got hematuria, of course, the patient should have a urinary catheter. Or if there is any urinary obstruction, O stands for obstruction or retention. So then there is a justification to keep the urinary bladder. U is after urological surgery. D is when they have decubitus ulcer or wound and the catheter is put to prevent urine soakage of the wound and to promote healing. I is input-output. If postoperatively there is a need to measure the input and output of the patient's urine output, then the catheter can be there. And when there is a need for end-of-life nursing, N, and then I stands for immobilization or neurogenic bladder. Okay, so this indication. So when these, now the five, how much is this? 1, 2, 3, 4, 5, 6, 7 indications are not there. Then they did a study where the nurse could just remove the catheter without informing anybody. So this autonomy was given to the nurses. So this, at the end of the study, it was done for about 6 months. They showed that the COTY rates were reduced by 73%. We are able to bring down the COTY rate by 3/4 just by empowering the nurses to take the catheters out with once any of these indications is not there. And because of this, overall, the device utilization in the hospital, that is the catheter device utilization, came down by less than 2%. And another important thing, you would have thought, okay, the nurses here in the crowd will think, oh, one more checklist for us. But actually, it showed that once the catheter is removed early, the number of hours per shift freed was 2 hours. 2 RN hours per shift was freed because not many catheters were there to monitor. So these are the advantages this study showed and proved. And there are several other studies which show overall CLABSI reduction of 40% in peds oncology, COTY reduction by 55% in a multi-center trial where 10 studies were reviewed, and WAP was reduced by 36% in a NICU. So all these were nurse-led initiatives which clearly showed HAI reduction across settings. So, friends, I want to argue that nurse-led initiatives saves lives and saves cost. So preventing a device-related HAI can reduce the patient risk of death by 10 to 25%. This is the WHO data. And there was this Brazilian ICU network study, a huge study, done all over Brazil, which showed that nurse-led initiatives can actually result in 570 rupees crore savings to the nation. And WHO also says that IPC bundles are always cost saving across all income levels. It doesn't matter whether you're a high income country or low and middle income group countries. In all settings, there is life saved and cost savings. So, as I told you, the nurses need not fear that this adds to our workload, because all these studies have also proven that nurse-led initiatives reduce repetitive tasks because the device is no longer there. So it saves time and convenience and confidence. And the link nurse model, where there are empowered and knowledgeable infection control nurses in each and every area of the hospital, reduces IPC burden, and this increases the trust amongst both the patients, doctors, and the nurses, reduces burnout amongst the nurses and doctors, and it boosts vigilance. So these are the facts, and we have to take from the studies which have been done in the last few years. I only looked at studies in the last 5 years. So also in India, there has been a study. There was a 39 hospital study amongst ICUs where the nurses applied case definitions with 98% accuracies. Some of the doctors here might have a doubt. Can we, give this empowerment to the nurses? And this study clearly shows the nurses are able to clearly define what is the onset of HAI and able to define these cases with 98% accuracy. And both NABH and ICMR supports the surveillance champions at this bedside. But in spite of all these studies happening, in spite of all these advantages being proven, still CLABSI rates remain at greater than 10% per 1,000 line days in many tertiary ICUs, as it has been proven in many studies, again done in the last a few years. So there is a great responsibility on all of us that we need to shift from passive to active surveillance and put the nurses squarely in charge of this active surveillance and empower them and give them autonomy. So appoint and train, there are 3 actions I would suggest we need to start from today or continue what we're doing today. Appoint and train nurse surveillance champions in infection control, adopt nurse-driven device removal protocols, and then provide simple checklists and dashboards to the leaders to show that these actions actually make a difference. So the best and effective infection prevention device is an empowered nurse at the bedside. That's what I want to argue. And as we all know, empowered nurses are real game changers. So with this sort of message, I'd like to now hand over to our guest, and I invite Stella to give introduction to our guest speaker. Thank you so much.
Thank you, sir.
Can I stop sharing?
Yes, sir. Sure.
You can continue.
Yes. Thank you so much, sir. And as usual, we had a lot of insights before beginning the topic, and we are waiting to hear from the speaker. And I'm so happy and I'm so glad to invite Sister Sai Bala, the esteemed nursing director at Amrita College of... I'm sorry. So some disturbance. So please mute yourself. I'm sorry for the interruptions. So I welcome Ms. Sai Bala, Sister Sai Bala, the esteemed nursing director at Amrita Institute of Medical Sciences, Cochin, with a master's in psychiatric nursing, and remarkably, she have started a community work at the age of 15. And she is a visionary nurse leader with a remarkable legacy in healthcare innovation and quality and education. She has played a pioneering role in national level initiatives such as National Consensus Forum on Wound Care, the Sankalp Leadership Summit, and the C20 Gender Equality Summit. And she is widely recognized for developing national guidelines on skin injuries and advancing nurse-led programs. She is an active member of Ethical Committee of KUHS since 2014 and associated with several national international bodies like INS, ANI, PCSI, AVA, and ISPN. She was the first in the country to receive a scholarship at the 38th Annual Convention of INS in Louisville, and the first in Kerala to set up the best practices in GI endoscopy. She has represented India at the 2nd Annual IB Global Summit on Perioperative Nursing in Dublin and has authored and co-authored various research papers. And I welcome you, ma'am. And before you begin with, it was quite difficult for me to shorten your profile because you have done a lot of achievements. And as Dr. Pari's profile, as usual when I work, I find a lot of difficulties to concise the profile. The same path I gone through while working on this. I'm very sorry, ma'am, if I have cut short on many things, but you have done a lot of things and I had a great work to cut short it. I think I have done some justice in the introduction.
Thank you, Stella.
Yeah,
I hope
it's all
yeah, I don't have a presentation, though. I would rather pick up from where Dr. Pari has started. We have, I think, 15 minutes to speak, so I would just share my experience and what I feel about nurse-led surveillance and active surveillance. I think it's a very important to understand the term surveillance when we talk about it. Surveillance, a lot of us, we think that it's about collecting data. Basically, surveillance is also about, analysis, interpretation, and dissemination. So the rest three parts, a lot of times, at least till maybe analysis sometimes happens, a lot of time happens for the sake of NABH and JCI and other accreditations. And in best of the best centers, they do, a lot of justice to analysis. When it comes to interpretation, there's still a little bit of a lag. And then when finally it comes to dissemination, I would say the dissemination to the authorities are always there, but the dissemination to the people who are actually providing us the data for running the programs are very, very limited. And when somebody talks about nurse-led infection control or nurse-led initiative for that matter, I somehow find it very, I don't know an exact word to say how I feel about it, because it's also like uh, everybody thinks when nurse is empowered, the responsibility becomes nursing's. And I think that should be thought out very differently, because the responsibility of infection control is everyone's in the institution. It has to be a culture. It has to be an everyday practice. Everyone is on to be the vigil. And surveillance, the process of actual surveillance that you talk about in the text, you know, real operational definitions have to be systematic, but a lot of factors that drive the surveillance can be nurse-led initiatives. So the initial thought was to bring in an ICN in the context of driving infection control. And a lot of time the role of an ICN was collecting data and bringing things to a physician's notice or an infection control or a microbiologist who was heading the team, and then go back and educate the nurses and train the nurses, and and they're supposed to highlight everybody else's flaws in infection control practices. And from there, it moved into learning about more about infection control, having a learned, though nurses have a minimum education on uh, infection control in the basic course. There has to be a very focused in infection control training program, which I learned from my experience. That when I started as a part of the infection control team in our setting, and it was because the infectious disease specialist left, and I was beginning the ongoing education department, and the infection control nurse was associated with me. And we were put together to find something to continue what she had actually put in the first surveillance program way back in 2003. And when we started the work, it was so difficult to find your data, to understand where to go, what to find, what was infection control per se. Though we understood from what checklists and all were this thing, but the basic concepts were still very, not very sure about it. So we started doing the first thing that we did was we developed a one-day module for infection control, on infection control basics and hospital-acquired infections. And that was the beginning. And then from there, the journey has been really, exciting. I would say adventurous, sometimes painful, sometimes very rewarding too. So from just having this small course and the whole, we saw the growth of infection control nurses being developed. We developed the first infection control certification program in 2011, and since then we have trained about 600 people across India. And I have seen many of them grow in their career. So the concept of nurse-led initiatives is basically that it's not limited to a group of individuals or one nurse. I think every nurse at the bedside should be empowered to speak up when it comes not only about infection control, anything related to the patient. So speaking up means that whenever you have a concern, that the power to talk, the power to speak up and say, okay, it's a doctor or whoever it is, it's even if it's a relative, whoever it is, you stand up and say, I have a concern and I would like you to look into this. This is I think maybe happening in a lot of corporate hospitals nowadays, but still it's a long way to go in many, many, many centers. A lot of times, infection control activities or surveillance limits to nursing practices on hand hygiene and nursing practices online and training nurses and training physicians. And that's it. So I would like to say that, we had very insightful discussions. Few of the case studies that I would like to share with you all. One was we had a Candida auris outbreak in NICU, and it's very, very, very difficult to control Candida auris. We did everything that we could do, but we just couldn't eliminate the fungi from the ICU. And then that was then when we put up the nursing heads, the floor nurses, and everybody, even the cleaning staff. We all sat together. We started looking at every single practice that we were doing. And one thing that we found missing was the cleansing of the equipments between when there was an emergency, we would transfer certain equipments from one bedside to another, or sometimes we had an emergency, we take it from another unit. So we just focused on, cleansing 3 times, cleansing the equipments in the ICU. Before I used to any patient, any new patient in the ICU, and anything that would go from one unit to the other would be disinfected properly. We had a protocol, and we used to do that. So 3 times cleansing, and we did not imagine the results that we saw in the next few weeks. The NICU was completely eradicated of Candida auris. So, we might think big things, but then see small things which we go unnoticed. That is where nurses can play a big role. And another incident of where we had the discussion on CLABSI in our VMD unit. So we had certain incidences which we thought was, we could be doing a lot more than what we were doing. We had a good reasonable good outcomes in BMT, and we're very less CLABSI, but still 1 or 2 would alert us, and we think, like, what did we miss? So we sat together and we kind of put together everything that we had to do, from line care to use of all the devices, connectors, and looked at cleansing protocols, terminal cleaning, intermittent cleaning. And we made sure that everything was listed down, everything was educated, right from the nurse to the housekeeping, to the bystander, to everybody, package of instructions being given, looking at any breach of practices by every single person was empowered, not only nurses. It was empowered but the nurses in the unit or the supervisor in charge would lead the team, because the BMT is a very small team. And then we found out that we could actually cut down the patient's movement from bone marrow to outside, and also cut down the when we bring in certain ultrasound machines or X-ray machines, when they come in, the cleaning protocol for that, or when the patient goes to an MRI or CT, that movement. These were also the risks that we had kind of missed. And when we put down the whole practices, charted out, made sure that every single thing is being looked after for every single patient that comes in, our line infections have literally come down to 0 and is being sustained. The sustenance, because there is a practice of discussing outcomes and any concerns at the end of every month with a team meeting. We also have a practice of raising concerns either by the physicians or by the nurses when they feel something is not going right. And we can call up a team meeting within the unit, or we can call up a team meeting with the administration. We have the freedom to given to the bedside nurse to talk up to the charge. It's like literally every nurse has entitled to raise a concern whenever there is something. But to bring I wouldn't say that everything is so perfect in the organization. Okay, I'm just saying that we are slowly growing from just having an ICN, just having linked nurses, just having projects, into empowering every single nurse with the knowledge. Immediate. The first thing is they have to know they have to have the know-how of what is to be looked at. So when you put a bundle checklist, it's just not the checklist. It's just that also what are we looking at and what's the outcome, and what is the practice and what is the outcome for that unit. So the dashboards that they use in the units to look at your practice and the outcome of the practice, and that reflects the ownership. The ownership naturally comes because you feel that you have contributed something better. So rather than just trying to pinpoint and say, okay, this is where we failed, we say that we change the focus from failures to success. We said that, from 85% we have come to 95%, or maybe 60. Why did we go to 70% this month? What happened in the unit? And that dialogues with the physicians, with the rest of the group, is actually evolving our infection control practices to be taken on a different level. So I would urge all of you to take this up and say that it is good to have an ICN. It's ideal to have an ICN. It's really good to have an infection control link nurse. But the infection control link nurses are not really meant to be infection control data collectors. The infection control link nurses are supposed to be the experts in the unit who will be educated continuously. So we have a system of having meetings every monthly. We share data, we discuss on concerns. So what happens is the infection control link nurse becomes the infection control specialist in the unit. And that helps the rest of the nurses to be trained and to be, looking at signs and symptoms, or unwanted tubes and lines, inadequate fixations, or somebody's practices are not really good. So you may not be able to go up and talk to the person whom you feel there has to be a discussion, but they have a pathway, like they can go to the next level senior of nursing, and the nursing heads would take up the responsibility to speaking up with the consultant or with the medical admin or with the doctor themselves. So there is like an open communication system that happens between different levels. And it's not easy to establish, and it's not impossible either. And I wouldn't say situations will be perfect at all times, but they, even if the surveillance have to really work, you have to have the understanding that there is a amount of data collection, there is some analysis, there is some interpretation, and there is a dissemination of information which is required. And this all this can be formal or informal, but the entire loop has to be completed. And just by giving some training, your responsibility does not you know end there. The information, the training is only one part of it, but monitoring, continuous monitoring of practices, going back to looking at any breaches in practices, discussing about concerns, coming up with an action plan, and following up, and a feedback, positive more than negative feedbacks, make a big impact in how you can actually change the scenario of infection in the country. I would say we have. If you ask me, what are some of the loopholes that I have seen? One is the contextual understanding. We look at bundles which are being used by the West. Our data in India is very limited. Data from nursing-led studies are very, very limited when you compare to the West. We do a lot of work, but we are very, when it comes to talking about what you are doing, we are a little shy. And maybe the nurses do a lot better job in India, but they would not come up with a thing because there's no platform. One second, even if there's a platform, if the ability for the organization to send them, or the nurse to take that lead and to talk, is a little lacking today, even today, with so many organizations. After Kaho has come, after all these learning opportunities have come, I've seen a tremendous thing. When we started in 2011, we were the only ones given the infection control certification program. And that why I did this, because when I went to Hong Kong to see the International Infection Control Nurses Conclave there with 1,100 delegates and huge studies, groups, discussions. I was wondering, like India has so many nurses and Hong Kong is such a small country and it has such an fantastic ICN meeting. Where are we compared to that? And then that actually gave me the courage to start up my program, even though I felt I was not really so fully equipped to do what I wanted to do. But I think this is, but it has also opened my eyes into, looking at how nurses can make an impact if they're actually empowered. Because when I started, it was so difficult for me to understand, to go to places like, if you are looking at best practices, you see there are WHO, CDC. Very recently, India has come up with some guidelines. So till then, we had to depend on the best. But a lot of times, what happens is we are not really practicing what best is practice. The base is still sometimes lacking. So when we talk about bundle checklist, when we talk about the tools that we are using, I think it needs to be changed to an Indian setting to understand or suit our practices. I would also like to share with you the experience of our pediatric cardiac unit, which handles very small, even neonates and with complex heart diseases. And we always had the maximum, I think, interactive infection control discussions on CLABSIs. Basically, CLABSIs happens in that unit. And that one unit actually, if you look at the standards, we are having a gold standard in infection control in pediatric cardiac, basically because of the empowerment of every single individual in that unit. It's and the nurses have the privilege to talk up when things are being raised, concerns are being raised. They always have the knowledge. We make sure that they understand what they're talking, and then they come up with concepts where they say, okay, this particular baby was admitted before, so was the infection before or after? So what did we miss here? So there are like a lot of protocols that are being led in our institutions because of these discussions, which are healthy and collaborative, which we developed over 25 years. It's not one day or 2 days, 25 years of work. And it's not simple, but I would say that every small attempt made would make a big impact in our settings. And nurses being at the bedside and being your constant monitors and using them to the best advantage would definitely improve the income, so the outcomes of the patient. But it also is not about adding one more job to the nurse at the bedside, because looking at the current scenario with a lot of newcomers in the system, it's very, very difficult for any single nurse to be doing all that, the infection control champion objectives that you're setting. So you need to be realistic to understand that whether the bedside nurse actually is able to give you what you're expecting, or if you have put a champion, the champion has to be freed so that she can work. Or if you're putting a person who's on the job, then the goals that we're setting for them should be very realistic. So these are some of things that I would love to share with you. I am sorry that I don't have a presentation, because I felt that I would be more useful if I share my life experiences with you, and then also make the program more interactive rather than a one-sided dialogue, monologue, I should say. So I think I'll just stop at this point, and Dr. Pari, if you want to ask some questions, or we'll just go on with the discussions.
Thank you so much, madam. I think that was amazing, insightful talk I've heard in a long time. And see, basically, the points which you raised about the resistant Candida infection being cleared by simple cleaning. I think it's a lesson every one of us have to take. We don't need high tech tools. We only need to be meticulous in what we do day in and day out. I think that makes a difference. I think that's an excellent point you made. And also, I mean, really what stirred me is when you told about the Hong Kong experience. So you have a huge alumni of ICU nurses, I mean, ICNs, and we have more than 400 plus ICNs with the Kaho skill summit course. So I think I will get in touch with you, and I think we should pull off a real, ICN, international ICN conference in the near future. I think we
Sure,
should
sir.
really do
We're
that.
very happy. Then
Yeah.
I was a part of the CPHIC basic and advanced course content development at work in
Yeah, I
Indonesia.
mean, if you really look at the other, nurses Kaho has touched, I think we will get more than 1,000 nurses for this conference.
Easily,
Really,
sir.
I think we should really work on that. I think there are a lot of questions which are coming, and I really encourage the audience to ask questions, because it is not every day that you get an opportunity to have somebody so experienced as this. So please take this opportunity, and I request my team to look both into the YouTube live and the Zoom windows, chat windows, to screen the questions and ask Madam those questions. Thank you. Over to you, Stella.
Thank you, sir. Usually, we used to get a lot of questions when they do the PowerPoint presentation. Ma'am, first of all, it's a clear mastery what you have done actually. It was like I felt like sitting in a place, no, listening to a live podcast. So, know about your experience in the infection control, and it was very great. I think so because of that we didn't got any questions. Like if all the audience were listening to ma'am, like no, what's about the story, what they have to do next. So all this things, amazing, ma'am. Thank you so much. Yeah. And no, dear participants, before heading up with the Q&A session, so there is a link which has been put in the no, in the chat box. You can click that link and fill the form to get the certification for the no, participating for this webinar. So now you can drop your questions related to today's topic, nurse-led surveillance. You can drop the questions here, or the three participants have raised the hands. How can I take that? Can we unmute you? And do you have any questions to ask on live?
Let us
Yes.
take the questions which are already asked. So, in the
No, sir, I
Q&A,
have gone through that. No questions were there from the beginning.
Q&A, there are about 7
Oh, in
questions.
the Q&A. Oh, I'm sorry. Yeah.
I think these are all related to protocols. I would
Yeah.
some of them you will have to probably go back and check on the guidelines, because I did not really bring in the every single guideline with me today. We'll have to go back and refer to them. But I would definitely love to talk to you on how to implement, if you have any hurdle on implementing something, some guidelines, you have something that you feel that nurses need to do, or something like that sort. I think that would be my area of expertise to discuss, because rest of the things that you're asking, most of them, if you Google it out, you can find out. There's very few answers that you can give today. Especially with AI, if you print the right question, you have the answers with 10 references.
Okay.
That will
Okay.
be a better option to answer.
Okay, ma'am. There is one question. I think you can help them out. There is a question from Sireng Lamo. So, what are all the challenges did your team encounter during audit or surveillance?
See, the one thing is that when you put up a checklist, most of the time the nurses or whoever is filling up the checklist does not understand the relevance of what they're doing. So it's important for them to understand that there's something called a knowledge pyramid. You know, it is, if you look at the Google, you can find out, you learn from it, because every data that you enters into gets into an information, gets into a knowledge, and then gets into wisdom. That means the strategies and the policies are made from the data that one is giving. So every single nurse who is actually doing the checklist need to understand that every data element matters in bringing the policies that they are to follow next in the. So if we enter a wrong data, the policy becomes wrong, or policy is not effective, or something becomes a burden. It's also because we have not really looked at the point of it. So one thing is about educating the need for doing the checklist. Second is that every time people talk about more and more forms and more writing for nurses. So That's something challenging to write, to balance between the data that the amount of data that you have to collect. And so I think it's also about integrating technology. So when it comes to integrating technology, it's also a challenge when you have one single company providing solution rather than 10 single things, say 10 different people coming with plugging solutions. So that is something that we also have faced when we were looking at automated solutions. But also then there is this second one is data collection, second is knowledge of the nurses, third is the communication with the physicians, or the especially with the consultants, or when there is a concern with the physician's behavior, or lack of practices that the nurses have to highlight, or when it sometimes when the patient gets sick and the doctors are very apprehensive and they really blame everybody else than looking into our team. So these are some things that happen because of the circumstances and the stress that everyone goes through. But overall, over a period of time, when at least some person in their unit is sensible enough to sit with everybody and kind of go through data, go through questions, have some success stories that they will share, like and say last time when we had this and we found out that something which was supposed to be disposable is being reused, who has changed the protocol, why did we do this? So these kind of conversation, when it started, the entire atmosphere becomes a little bit more friendly. We still have challenges with many people. It's human beings, and behavior doesn't change overnight. It is the belief systems which fosters behavior, and I think our education is still lacking in understanding that. And sometimes instead of focusing on changing beliefs, we focus on changing behaviors. It's like scrubbing the a pot, and then you put again back again, the fire will becomes black again. So basically you need to have to change the texture of the material so that you can. So infection control is 10% science and 90% behavior. So I think the cleanliness, the concept of cleanliness, that is to be engraved into every single person's mind. If that happens, then infection control really becomes successful. Otherwise, we still have a lot of hurdles and challenges with related to knowledge, with related to skills that are required, with related to conversations and effective communications, and with related to basic human behavior in a nutshell to say.
Thank you so much, ma'am. And there is another interesting question for you, madam. Like it is about like, have you encountered the friction from doctors when you initiated nurses surveillance in your hospital, and how did you navigate this challenge?
Definitely, lot of that. We are still navigating because every doctor is not the same. It's not about being a doctor. I think it's also about when you look at a physician versus a nurse. I would say the physician carries a lot more burden than the nurse on their shoulders, because if a physician touches a patient, it's a lifelong liability. Whereas a nurse touches a patient after the end of the shift, she can walk off. People wouldn't remember the nurse. Advantages and disadvantages at the same time, because you finish a shift and you can walk off, and nobody really looks at whether you have washed your hands, whether you actually scrub the hub every time you did. No one, no patient is going to know, but the doctor has a more liability. And then I think the system also has a way of putting a complete moral responsibility of every patient health on the physicians. So they tend to be much more, defensive in the first go, thinking that, if you are responsible for a life, you wouldn't want to be feeling that, I didn't do things well. The first thing would be all want is to say that I did everything. I could what I did do whatever is possible. Rest of the team, they all have contributed, or we try to put the so that you feel little distress, less distress. That's all what is happening. So when we take the when this junior nurses cannot talk, a lot of time it doesn't happen. Junior nurses cannot put the concerns right to the physician. So the nurse manager level tries to interfere. If that doesn't happen, the next level, that doesn't happen, comes to next level. So when it comes to my level, I would sometimes, if I have to go and sit with them and discuss, I would do that. It's like it's not one solution. I would say it's the constant attempt for a dialogue. A lot of times it helps when you bring evidences and say that this is the evidence that talks about uh, what practices would be required. Or sometimes we say these are the data. We would collect data and keep it till we have enough data, and we go back and say, okay, see, doc, this is what we have seen. These are the many things that we have seen, and we would think that probably we should sit together and change our policy. So those things have worked with us a lot. When you talk with evidences, when you talk with scientific evidence, sometimes we talk with bedside evidence. Sometimes we give incidences and highlight certain things that are missing, not like a blaming culture. So I think it's all about understanding each other, and that makes a big difference in how you can work with the physicians.
Well, I think there are a few people who raised hands. So you want to give
Yeah,
them?
yes, sir. Yes, sure, sir. So, Atul Tayade. So you can unmute yourself and you can raise your question here. I have given the access to you.
Probably can unmute all of them. About 6 of them are there.
Yeah. You have unmuted already? Already, sir. It's done already.
Okay.
Yeah.
So I think
So,
people who raised hands, no, you can unmute and talk, and
yes.
we will hear you.
Yes, Atul Tayade. Yeah. You have unmuted yourself and I think you're ready to talk now. You can ask the question. Okay.
Meanwhile, I think another interesting question is how do we make sure that checklists don't become tick lists? Somebody is
Tick
asking.
list. Yeah.
So that's the first answer I give. You actually have to make them understand the knowledge pyramid and tell them that, whatever you tick off is coming back to you as an
Why they are doing what they are doing? I think that's very important.
That's second thing is also important is to look at that how many checklists are we giving them to do? And is it possible for any single nurse in a shift to complete all that if they do their work well? I feel we still burdening them with a lot of checklists that multiplied entries, data entries, and
True, yeah,
points.
very true.
I
Thank you.
think some kind of an integration of our record system needs to be done to reduce this. So it's not one thing that we can do, but it is important to sit with the team and understand why they're doing it. So maybe it's a time, maybe it's the schedules that we have done, maybe it's too much of data, maybe they don't understand. So there'll be multiple reasons. I think we need to look at our reasons and try to address them one by one. Maybe we won't be able to make big differences, but at least we can make some difference.
I think it's a very, very practical, answer. Now, most of the time it is too many, checklists which really
Checklist.
burdens. Yeah.
The nurse to
And
patient ratio and workload that matters.
Yeah.
okay. So the permissions have been already given to the participant who have raised their hand. Yes, Ivy. So do you want to ask something? Already the permission is granted. You can unmute yourself and you can ask the questions here.
Doesn't look.
Okay. Yeah. Sering Lamo, do you want to ask something?
Yeah, somebody's asked about the recording of the session. Yes, it is being recorded and it will be live on YouTube by the end of this week.
Okay. Hi, ma'am. Good afternoon to everyone. Ma'am, it was a very enlightening discussion, and it was like we had a great experience listening to your personal experience, like as an infection control, like committed to an infection control person. And then I just have one like a little like query. As ma'am, like during your like experiences when you are delivering and working so dedicatedly for the infection preventions and control, I just want to know that whenever we go in the ward as an ICN, we are always stared by the people, by our own people, in fact, our own staff, as in foreign element, as in a foreign item, no? So it
Yes.
becomes like very hard to like initiate communication or our conversations with them on that basis. So I just want to know that, ma'am, that ever like in your life you have faced that, and how you were like able to overcome it, because that is the biggest challenge for us, like everywhere whenever we go in some areas and all. So I just want to know that, ma'am, like how you were able to overcome that.
Actually, I did not have the fortune to work as an ICN, but I've always been a leader. So you actually land up policing a lot of people. That
Yes,
is
ma'am.
that is inevitable. But the thing is, I think it's about the intent and our focus on, see, what happens when you become a specialist. When you become a specialist, focus on the thing that we are supposed to do. So
Hmm.
whenever my secret recipe would be to think from whenever I speak from the other person's point of view. So if I were to talk about no, a lack of hand hygiene or doing something
Hmm.
in the unit, I would ask them why. What do you think would help? Uh,
Hmm.
I can do to help you in
Hmm.
order to change the things that we want you to change, or maybe like how can we help each other to do things better?
Yes,
So
ma'am.
that would be the
Hmm.
best way to put up a dialogue, because the moment you see, the thing is, if you look at a bedside nurse,
Hmm.
there are 101 things in their head. And as an ICN, what we want to do is hand hygiene. Do you think practically is it possible to do the 6 moments of hygiene every single time in a shift? Impossible.
Hmm. Hmm.
So
Yes,
if you
ma'am.
talk about too much techniques and too much details, it becomes they become too apprehensive, and then the more they are apprehensive, the more difficult for them to practice the basic things. So what I would always say is that think about cleanliness in every step of your life.
Yeah.
So at the moment that the concept of cleanliness comes into your system, naturally your practices improve. So I think that's exactly what I was trying to say to, look at your belief systems. What do you believe is
Hmm.
right? And why do you
Hmm.
think that should be done? So it is
Hmm.
not a one-day story, but I think the moment they see you as a friend, they see you as
Hmm.
somebody who will raise the concerns that they have in a positive manner, you will be more.
Hmm. Yes, ma'am.
But there will
Yeah.
definitely be people who will not be very happy with you. But I think any administrator, any leader cannot be a friend for everybody.
Yes,
You
exactly.
have to be. But then the thing is also that when people understand that you talk from the point of a patient's perspective, and you uphold those qualities inside you,
Hmm.
though they might have disagreements, though they might not be very happy, I am sure they would definitely have a lot of respect and love for you. And that's the matter.
Yes, ma'am.
Fine.
Yeah. Thank you so much, ma'am. Thank you.
So I think there
Okay.
was a question.
Yeah. There is another question in the YouTube live, sir.
Mhm.
So, from the participant Annie Benjamin. So, she have asked, do you think a reminder note on hospital walls can help cross infection through patient attenders?
Definitely, because see, patient attenders, there is it's a double-edged sword of teaching your patient attenders. Because if you don't want them to come and ask questions to the nurses, then you better be careful. But I would say that it is an added advantage, because the culture also should be like this, that I am dealing with 10 people. I may not be able to remember every small thing, but I would want you to help me remember the best things that I can do for your patient. So that kind of a mindset has to come, putting up posters. And every time you see an ad 100 times, when you want to go to a product, to buy a product, you would remember that brand, that ad. Okay, so reminders do a lot of, especially visual reminders, do a lot in teaching. Not only bystanders, when you put reminders for which are meant to be for bystanders or for nurses, everyone else who sees it 110 times, every time they pass by, this unconscious, effortless learning that happens, and that actually will add a lot into ingraining certain practices into your system and culture.
Thank you so much, ma'am. So, I think The others have put down their hands. They have lowered their hands.
No, I lowered it because
You have lowered it? Okay, okay.
none of them
One.
actually unmuted. If they want to, they
Yeah.
can raise their hands again.
So there was some question, because if I go and tell if your cases have ended up in a SSI, many of the doctors are not expecting the same. How can we handle this type of situation? I would say that, where you would put up an appointment request with that doctor, go and say that these are the definitions for an SSI. And this is what I find in these patients. Would you think that would you help me clarify whether how do you think this would be an SSI or not? No, you can approach your physicians different. Every physician is not the same. Some people are unapproachable. So when it comes to those levels, you have to use other people whom you can talk to, whom can be useful for raising the concern. Sometimes you can go and have a clarifying doubt kind of an approach. A lot of times people do agree, because I told you, when you try to say that your patient has an SSI, the immediate thing is that I did something wrong. That is how people perceive it. So I think we should rather use that. How can we confirm whether this is an ISSI or not? These are definitions. I find these criteria, and I find these in the patients. Can we agree on this is an infection or not? How can I help you in getting lesser? And I don't think any doctor is against infection control. They just become too defensive because they feel that the entire blame on all the wrong is coming on their shoulders.
Yeah, I think as a surgeon,
It's absolutely not true, because it's from the housekeeping to the PG to the intern to the nurse to anyone who touches the bed is actually responsible for, because the environmental cleanliness, the hand cleanliness of the hands, these two are very, very important factors when it comes to a lot of infections today. So that I think every single person is responsible. So it's not the blame is not on any one healthcare professional. It is all of us, including the relatives, who has to think about bringing in the best practices and best outcomes. And we have to work together. We might not be very, uh, you know, ideally successful or the best ideal place, but we can be a lot better than what we were yesterday. So I think that's what we have to look at, rather than focusing on zero outcomes and zero. We have to look at how much have our system been positive to criticisms, to open conversations, to constructive criticism, changing changing the culture into a more friendly workspace. That will change the infection control data and the infections too.
I think that's true of every change we're trying to make, quality, patient safety, everything. So I think,
Yes.
even when I go and do the, quality and patient safety talks, the same question, the quality managers come and ask me the same question. How do we make the doctors see their point of view? But I think a valid point which you raised is see, from their point of view. I think
Yes.
that's a very valuable lesson. I think all of you have to really learn. See, as a surgeon, now I'm a surgeon, and if you come and tell me your case has got an SSI, as madam said, the immediate is to go on the defensive. So instead of that, frame your response or frame your query in a different manner, understanding this particular defensiveness of the doctor. I think that is very, very important. Still, I think again, who's raised a hand? Sering Lamo has raised.
Sering Lamo have raised it.
Yeah.
Okay.
Ma'am, I was just wondering, ma'am, like as in being an infection control leader, you must have come across many instances and incidences where, despite repeated requests, the concerned healthcare workers or the staffs are not actually compiling to the protocols or the unit protocols. So in such cases, as a leader, ma'am, what was your approach?
I actually would look at the positive outcomes and avoid them rather than look at not compliances.
Okay. And then, ma'am, the second thing comes if, like, suppose if our approach is positive, we want to keep a positive approach, we want to like motivate, we want to give them some sort of incentives and all. But then if in case the administration is not in support of it, then how you'll go about it, ma'am?
See, basically, it's not about incentive. Okay, there are certain things that we can do. One is if there is there are not one intervention would not help you. One is that we will have to educate them on what was the impact of their behavior. Okay, this
Yes,
was what
ma'am.
your behavior. This is the impact of the behavior. So if you focus on changing the focus on changing the behavior and the impact, how it relates to impact. So if I was actually able to understand it and look at every single person's face and see how you feel when I'm talking, the way I would modulate would be very different, right? So when I'm actually assuming so many things and working, my way of conversation, my style will be very different. So I think the
Yes.
information part is very, very important. Second thing is that whenever somebody doesn't comply multiple times, I think the question has to be why that person is not able to comply. Is it a person problem or is it a system problem or is it a the process problem? So if it's a system problem, I think we'll have to address the system. Okay. If it's a person-related issue, then I think we'll have to look at how we approach is whenever there's a problem with a person who's not following protocols continuously. There's no system issue. It's a person-related problem. The first question we would ask is what is happening with your life? Because if
Yeah.
something is happening with their life, then it's very, very difficult for them to focus on their work, especially the small
Exactly.
details. So in such cases, I think the intervention would be very, very personal, and sometimes you will have to go to the extent of counseling, pulling them off from the unit, changing different, like addressing their apprehension. So that's another way. So there
Yeah.
are not one improve. So you will have to do one is that constant feedback. Second is that the feeling that somebody is actually monitoring, because it's important. If I were to, if I didn't have 101 class tests and I
Yes,
only
ma'am.
had a major exam, I would not really look and read every day. Third is also setting up reminders, like visual reminders.
Yeah.
More today's generation, I think we should have more games because,
Yes.
and there's more of these, reels, 1 minute, 30-second reels that can go sometimes into your system that will actually bring back certain things. But we can use
Yeah.
technology for advantage. Second is also
Mm.
like making them understand the consequences of their action. I'm sure that no human care worker would be very happy to know that whatever because of their practices something bad happened. That is, and I don't think anybody would do. The only
Yes,
thing is
ma'am.
that the way we handle it is what makes the big difference.
Yes, ma'am. Exactly. Thank you, ma'am.
Thank you.
Okay. So I think there was one question, and Mr. Rajaraman have answered for this question. So they've asked how to clean the post-surgical instruments.
Yeah, then these protocol related things, let's not,
Yes.
do that, because I think we need to tap the wisdom.
Yes. Okay. So how frequently we should call the post-surgical patient and do the follow-up? And who should call?
Again,
Post-surgical?
Post-surgical patients. Like
Post-op
how
patient.
often we should, yeah, post-op patients.
No, it depends on your institution's protocol, depends on the department, because each department will have their the vulnerability. Based on the risk and the vulnerability, you'll have to fix up your protocols. So it depends on the resources too. If you have too many people, you can call very often. If you don't have, then you'll have to schedule accordingly.
Yes. Great answer.
It's like look at the stand. I would always advise you to please look at the Western standards with a skeptical view, because the workload of every single nurse and every single person is less compared to us. So in certain areas at least. So and also that the resources, the understanding is very, very different. So you will have to have certain methodologies which are very contextual. Also, we should have an approach which is very contextual for your infection control program to be successful. It is very good to look at standards guideline, but please make your own data. Look at your own studies. We don't, even if you don't publish it, look at your data and create your own evidence from your organization. That will help us a lot.
I think there's a very good question, Ms. Samer. Is if there is a single best advice you could give to our ICNs, what will it be?
Talk about cleanliness, cleanliness, cleanliness every time, and then say that infection control is all about cleanliness. That's it. Don't talk too much of infection control jargon. Just talk about uh, staying and doing the things in a clean manner. That's it. And that would go into the people's head much faster than talking about all these other things. And always, keep look at yourself. How you were 10 years ago or maybe 5 days ago, and compare yourself and reflect upon your growth. So that will keep you inspiring to go in your journey. It's not easy to be an ICN when you're actually policing a lot of people and people are not very happy with you the way you are. And so it's sometimes you just feel that, why should I do all this? But look at what you were, how you've grown, and look at what impact you have been able to make with your interventions. Once in a while, go back and look at yourself, and it will help you, stay motivated.
Other
I
interesting,
think, yeah.
another interesting question is, we've been talking about doctors, but this person has asked, what are the challenges you faced from the nurses when you started implementing surveillance and empowering nurses, trying to empower them?
I think empowerment, the understanding of empowerment is very, very important, because when you think that empowerment is given to a nurse, the nurse wouldn't want to take it. The empowerment, they have to feel that they already have the power and they're not using it. You have something in your hand, you're not using it. And like if I say that I have a certain instrument and I would like to give it to you, people will say, why do I need it? When you say that you already have it, and why don't you use it to your best advantage? I don't think that people would have problems. But the thing is, there's a lot of resistance when it comes to certain behavior. But I believe that every human being has a potential to change. And as a leader, it's our responsibility to find out the best way we can do to bring that change in them. Nurses have been the most difficult people to handle. I would say at sometimes I faced more resistance from nurses than doctors. The only thing was to educate them. For nurses, it was education. For doctors, it was data.
Yeah, and also I think, though I use the example of the Houdini study, doing that in our country would be very difficult. Now, if you tell that a nurse can remove a urinary catheter without telling the doctor, in our culture, of where the doctors have this sort of outlook, it's going to be difficult. So we can't just take those studies from the West and try and implement. I think that's very
But
important.
I think one thing they can always do is when you have somebody walk in and checking, like, once in 2 days or something, go around and see how many follies could have been removed based on a certain criteria, and raise a concern with one person in the department who owns up the process. So there's a multiple owner thing. So between them, if they have an agreement, we can still implement these things. So there
Yeah,
are ways.
I think this one change which I've seen in theater is the timeout. So when the circulating nurse comes and starts, initially there was a lot of resistance from our, surgeons, but now after about 2 years, it has now become a routine. So we need to start somewhere, and then the nurse starts, gets empowered over time.
Yeah, I think it's also that, when you start, so there are there is like one whole process has to be there. It's not one thing. It's one is education, second is monitoring, third is feedback, and fourth is reinforcement. All these things have to simultaneously go for any process to sustain. Even if it's running okay, the regular monitoring in terms of regular criteria, and also once in a while audits of best practices, compliances, these all need to be combined. Without that, any process to sustain in a very changing environment is very, very difficult.
So I think, any more questions? Can we?
Yes, sir. The last one question, because I was just skimming the questions, like, which I'm not able to skip off. That is like how to maintain the infection control program in comprehensive way in the resource limited and in the understaffed healthcare settings?
The thing is, see, we'll have to look at if you dream big and you don't have the money to live that life, and it's going to be very difficult to attain it. Either you make the money or you dream less. That's the only thing. So if you feel the resource is limited, then use your resources to the best thing. So you have to prioritize what you want to do and why you want to do it based on certain criteria for in your own organization. So that's the way to go forward. So if you do good with good resources, limited resources, people will be very happy to give you more resources because you are showing the outcomes. So the thing is all about using your resource wisely and effectively. I think that would be my answer.
Amazing,
Yes.
amazing answer.
I think that is about, sir.
Sure. Mr. Rajaraman,
Yes.
you want to give some concluding remarks?
I think it was a great lesson on management and managing people, leadership up above. I think it was great learning for me as well. I think really thank you, ma'am, for the insights. I think getting and managing people is very, very important. I think that's the fundamental takeaway I took from your sessions.
Make things simple.
Yeah.
That's it. If you make it too complicated, people will think that it's not for me. It's for somebody who's more educated or who holds a bigger position. So make things very simple. So it's all simple only. But the only thing is that when you talk big jargons, it looks like it's not quite possible to do. So when you break the things into simple life day-to-day practices, it's not difficult to practice infection.
Just one final thing, Rajaraman, before we leave. I think there was a lot of comments saying, where are the slides? Where are the slides? But this session showed, I mean, we were so hung up on this PowerPoint and slides, but the amount of wisdom we got from this session is much more than we could have got with the structured PowerPoint presentation. So I think that's something which all of us have to take back from this session.
Yeah, I think we should. It would have been very difficult to put these things in the slide. You would have covered only 25% of what I talked otherwise.
Definitely.
Yeah.
Thank you very much.
Thank you all.
Thank you,
Thank
Dr.
you for the opportunity. Thank you, Dr. Padi and Dr.
Thank you so much, ma'am.
Thank you, Stella.
Thank you so much, ma'am. Thank you so much.
Thank you all the participants for being such a lively audience. Despite being a Zoom, I really felt that I was in a live podcast actually. Rather a live show because there is a lot of feedback.
Just look at the hearts which are going up. That shows.
Hearts, yeah, hearts and thumbs up.
That's what I said. So usually what happens is you feel that you're looking at a blank screen. I can feel the people. So I feel that this has been a wonderful.
It's now increasing. It's decorating the entire screen actually.
Thank you very much.
Thank you so much, ma'am. It's all about what you have given for all the healthcare professionals and all the nurses who have participated here. You have given the life lessons, to be very simple in the healthcare setting to achieve the success. Thank you so much, ma'am. And I also had a lot of learnings from you. Thank you.
Thank you very much.
Yes.
Thank you so much. Stella, you're going to stay on for some time?
Yes, sir, because the feedback forms are on here. So I need to sort out these things and then we'll be binding off. I think you can sign off, sir. And even Mr. Rajaraman, we can connect off that. Thank you so much, sir. And thank you so much.
Thanks, Rajaraman.
I also leave. Thank you.
Thank you.
We have to thank 𝐏𝐿𝐾 for the support they're giving and making these sessions possible. Thank you.
Yes, really great. Yeah.
Thank you.
And I think, Jay, you can post the feedback link here again. I think a lot of messages have, pushed the message up for there. Yes. You have got the messages here. I think, a lot of comments are coming up here. So that's why you're not able to look up the link. Now the link is there in the chat box. You can again click it up and then you can fill the form. Once you have filled the form, you can, log off from this Zoom room. You will be getting your certificate after 48 hours of time, or might be after 3 to 4 days, because it's like a huge number of participants we have for this webinar. That's why there are like a lot of challenges to send out the like certificates like within 48 hours of time, but you'll be getting it in your inbox. Thank you so much. And also the YouTube participants, I would like to highlight in the YouTube channel, in the chat box, there is the link again there. You don't have to log off from that system, and you don't have to log into the Zoom to fill your forms. It's for your easy and for your convenience. We have posted the feedback form in the YouTube even. Thank you.